Hospitals Finance Committee. Today's meeting is officially called to order. According to the bylaws of Section 14, committee attendance, if any member of a standing or special committee of the board will not be present at a scheduled committee meeting, the member may ask the chair of the board to request that another board member, not a member of that committee, attend the scheduled meeting and be counted as a member for purposes of quorum and voting. Therefore, Sally Hernandez-Pinheiro has authorized Molly Wassaw Park, represented by Karen St. Hilaire, to be counted for the purposes of quorum and voting on her behalf. I would first like to propose a motion to adopt the minutes of the Finance Committee meeting held on October 7th, 2025. Do I have a second?
Second.
Oh, lots of seconds. All those in favor?
Yes.
Yes? Any opposed? Okay, the minutes are adopted. And we have, unusual for this time, a full session available for a financial update from the financing team, so I see a lot of the members here. We look forward to hearing the report that we were able to get to last month.
Yes. No, we very much appreciate, the extension of the time, right? Because we always feel like we don't get to the end of the deck, which is equally as important as the beginning of the deck.
Yes.
So, and we actually took the opportunity to add a little more information, right? Starting with rev cycle. I think Margie's taking well-deserved vacation, so Allison is filling in for her. So I'll turn it over to Allison, and we'll go through the first slide.
Thank you.
Good. Hi, good morning, everyone. I'm Allison Hartman. I'm the AVP for Patient Access in Central Office Revenue Cycle Services, presenting on behalf of Margie. And what I wanted to do this morning is really just give an overall recap of our FY25 revenue cycle accomplishments and dive into a little bit more detail about what our current focus is for the current fiscal year. Overall, our initiatives generated $760 million in FY25, which is a $309 million increase over the prior fiscal year. And that included improvements in our overall financial counseling performance, which generated $202 million, coding documentation improvements generating $171 million, a reduction in our accounts receivable by 31%, which accelerated $50 million in reimbursement. Our No Claim Left Behind initiative, which is really a focus on reducing write-offs and trying to get paid on every claim, generated $14 million. Our Revenue Cycle Institute resulted in 14,000 class completions that included instructor-led and e-learning modules and resulted in 382 graduates from our Revenue Cycle New Employee Onboarding Program. Our focus on DRG validation, as well as appealing downgrades, yielded over $10 million. We developed an internal process to review payment variances, which saved over $3 million in vendor fees. We led an initiative to reduce providers' open charts by 58%, which generated over $8 million. Our revenue cycle quality assurance team audited over 9,000 accounts for almost 1,500 individuals, providing an opportunity to identify trends in challenges, recommend training, and coach those individuals. Our one-stop benefits initiative expanded from a small pilot to now being the core work of our full telephonic financial counseling team. And last year, we screened over 7,000 patients and completed referrals or applications for over 10,000 benefits. We also developed and deployed an AI utilization management screening tool to reduce inpatient medical necessity denials by trying to get the diagnosis right up front. Looking ahead, really our current focus, which I'll get into in a little bit more detail in a moment, is facilitating really the implementation of best practice workflows uniformly across our H&H facilities, just continuing our ongoing journey of trying to get to Epic and industry best practice. We're also looking ahead to redesign our financial counseling process to incorporate AI to try to handle the anticipated increase in Medicaid redeterminations and just overall increase in financial counseling volume. Just in terms of our current focus on targeting best practice, there's been a substantial amount of improvement really over the last several years in terms of revenue cycle performance, but there are still varying levels of performance across our H&H facilities. with some really doing well across the board, but others potentially doing well on some in some areas, but not others. So we've identified some improvement by standardizing individual facility performance to the internal best practice, really trying to raise the level of performance for those facilities who might not be performing as well as some of their peers in these particular areas, and doing that by really looking to roll out our best practice standard work that's based on really learning from the facilities that are performing well, as well as just incorporating overall industry best practices. So we selected 8 metrics that are listed here, really across the spectrum of the revenue cycle, and looked at really what would be the opportunity to bring all of our facilities up to our internal best practice, and then eventually just overall industry best practice in all of these areas. That opportunity we calculated at almost $200 million, and set a budget target of $54 million in FY26, ramping up to that full opportunity in FY27. And our current work with the facilities is really looking to implement, again, that standard work that was developed with the top performers, incorporating just overall industry best practice, and looking to create initiatives really in each of these areas to raise the bar, and look to increase the performance again to just bring everybody up to our best performers.
A question on that? And thank you. John will kind of pause. I have a question here from Sally. So thank you. First, just the revenue cycle accomplishments, she says, are just remarkable, and congratulations, and I would echo that. But she asks, how did we redesign financial counseling, the financial counseling process to incorporate AI to handle increase in Medicaid recertifications?
So that's really a current body of work that's still in development. With the federal budget reconciliation and the upcoming changes to Medicaid recertification requirements, people having to recertify more frequently, as well as changes in eligibility that might result in more people needing financial counseling, we're looking at ways to incorporate AI into our financial counseling process so that we can serve this larger population of folks who need assistance in a more streamlined way for our staff as well. So still work in progress. We've not implemented that yet, but it is in development.
But isn't the idea, Allison, like that we'll get AI assistants to do the financial counseling and go as far as the AI assistants will take us, and then
Right.
switch over to our own staff if we have to. So
Right.
it really allows us to introduce, right, AI. Understanding full well, some people will gravitate to it and be just fine. Others will say, I really want to talk to a human, and we'll flip back over. But with the HR 1 bill and a recertification every 6 months, the volume in essence doubles, right? So we have to find a way, right, to make ourselves available more frequently without interruption. So we thought we'll try this AI assistance approach.
That makes sense. And then I think you mentioned that you're already using AI to help screen for denials. Is that right?
Yeah, the tool that was developed really is a tool to assist providers in getting the diagnosis right up front for people who are admitted as inpatients, to support that admission.
Got it. That's good. Other questions from committee members on the revenue cycle?
I had a quick question on how much variation there is across facilities when it comes to these 8 metrics. Is it a lot, a little? Because I see the estimates of 187 million by 27, and just wanted to get a sense of.
Yeah, there's definitely a fair amount of variability by facility. There's definitely a few facilities that are top performers across the board on almost all of the metrics. And where some facilities are potentially not quite at that level, it varies quite a bit facility by facility where the opportunity really is, which is why we really looked to, again, sort of learn from the facilities who are performing at that highest level, share their best practices with those facilities that might be struggling a little bit in some of those areas.
Yeah, on my view, it's really opened up the conversation, I think, in a positive way. When you can show one facility's, up here as the top performer, then you ask yourselves, well, why can't we get there, right? And then that invites conversation between the facilities, and we try to help, coordinate that. And the idea here is we're going to come together, develop a plan first around the 54 million, but really it's to shoot for the 187 for next year because we're kind of trying to plan ahead. And we're going to give each facility their choice in terms of, well, which of these various initiatives do you want to attack and invest in? Because to try to do all 7 or 8 all at once is very difficult, right? So we're giving them that choice of where do you want to focus first.
Right.
So we're pleased so far, right? But it'll bear out in the numbers in the end, right? That's the way it works, right? If we be successful, will we achieve the 187 target? And I think we're well on our way at the 54, right? I think we're,
Yeah, already seeing some improvement.
It'll be great to learn more about how, sort of like, what you learn through that process, because this is something that comes up a lot in a large system like this with 11 hospitals, and it's always a question in the back of my mind, like, and many board members, I'm sure, like, how do we take what somebody's doing and translate it? It's always a struggle.
yes. I think learning from ourselves, the system seems to do better, right? Versus
Well, I was going to say, this is like a benefit of us being a
Yes.
big diverse system, where normally you're benchmarking against other hospitals around the city and, not related to us, et cetera. And so this, we have the benefit of actually being able to share that information. So I think to Jose's point, seeing how that goes would be very interesting.
Yeah. We're excited to report back on how we do here. We're putting collective pressure on ourselves, to hit these metrics. And I think so far the facilities have been doing, a good job. We gave ourselves, the end of the month or something to put together the plan. But we'll have to find it.
Maybe it's worth pointing out, John, just for the board's interest, this was not our first proposal. Our first proposal was to centralize the process. And facilities were very negative on that. And so, we said, okay, well, that's okay. Our goal was not to centralize. Our goal was to get everybody up. So if you can get up without centralizing it, then that's great. So it'll be interesting to see.
Yes.
But they're very motivated for that reason. They did not want to see the resources become a centralized resource. They wanted to keep it at their facilities. It's interesting.
Yeah, but if you can hit the target.
If they hit the target, it's the same thing. Doesn't matter to us.
Right, and it allows us to retain the individuality. So
Right.
It's good.
Yeah, I think at the end of the day, right, we're just trying to achieve best practice, right? Whether it's centralized, when I would hear the conversation, like, well, those are all the things we wanted to achieve if we centralized it. So in essence, we're just accomplishing best practice
Correct.
in a different way, right? And I think, right, and it's healthy tension in an environment, right? It created this healthy tension that I think we're all responding to. So again, we'll see how it goes.
Well, we look forward to the report on how it goes.
Yes.
Thank you. So no other questions on revenue cycle. Thank you, Allison and Megan. Yeah, great.
Good morning. So I have some value-based payment updates that we're going to go through here. So we're first highlighting here our Health and Hospitals ACO. So since 2013, New York City Health and Hospitals Accountable Care Organization has participated in the Medicare Shared Savings Program, which is run federally by the Center for Medicare and Medicaid Services, CMS. As of 2025, there were 476 ACOs that participate nationwide, of which 13 ACOs are from New York State. So ours is one of 13 in New York. The goal of the program is to manage the care of attributed patients with traditional Medicare coverage. So that's your parts A for hospitalization and B for physician services. And the savings that are achieved by the Medicare Shared Savings Program are then shared back to the ACO. So the New York City Health and Hospitals ACO has about 5,400 patients, and they're managed predominantly by doctors practicing primary care at New York City Health and Hospitals. That's about 96% of our ACO. And then the remaining doctors are affiliated with a federally qualified health center called Community Healthcare Network that has branches across the city. And since 2019, the New York City Health and Hospitals ACO has held an enhanced track contract, which means that it has two-sided risk with CMS whereby the ACO is taking the greatest amount of financial risk. So we can get up to 75% of program savings. Next slide. So we just found out a month or two ago that CMS has announced that our Medicare Shared Savings ACO achieved 12 consecutive years of shared savings. This most recent program year, which is for calendar year 2024, we saved the Medicare program $9.8 million. And because of our high quality score, we were able to retain 7.2 million of that 9.8. So we're really pleased and excited about that. You can see at the bottom that over the full lifespan of our ACO, we've saved Medicare over $100 million, and we've been able to retain 60.5 million of that.
It's very impressive.
So then just giving you a quick snapshot of our larger value-based payment portfolio, right? So Health and Hospitals participates in several value-based payment programs in the New York City market. So you can see we're highlighting 4 here. So the first is MetroPlus. So we've had a value-based program with MetroPlus for 23 years. As of August 2025, we had 368,677 people. We're taking upside and downside risk. Our shared savings in 2024 calendar year were $332 million. And on top of that, we have a percentage of premium that is withheld to earn back for our quality performance. And so we were able to earn $13.6 million, which is a large chunk of what was reserved. Similarly to Health First, you can see that we've been partnering with them for almost as long. We have a slightly smaller risk pool of 176,000 people. We take upside and downside risk. We were able to save $83.8 million in calendar year 2024, and an equivalently sized quality performance. And to note, we've shared with the board before that our Health and Hospitals facilities are performing at the top tier of the Health First quality program. So we're really excited about that. The MSSP is the ACO that we just talked about. So again, we've been with that 13 years. We have about 5,400 members. We just covered that we earned $7.2 million in 2024. And we don't have an extra quality award for the ACO. Essentially, there's different ways to design a value-based program. So for this MSSP, the amount of money that we can earn in shared savings is directly tied to the quality. Whereas with Health First and MetroPlus, at the start of the year, we're withholding a piece of premium that we can then earn back. So it's just a different mechanism by which we're administering the program. And then last but not least, we have a small value-based contract with Fidelis Care for Medicaid lives. We've been in the program for about 5 years. We have 9,338 folks enrolled as of August. We have a limited risk where we're kind of capped at how much we can earn and how much we can lose. So we're not at full risk. So that's a little bit different with the Fidelis program. Also because it's smaller, so there's more volatility in that program. We haven't yet received our performance score for 2024, but we expect it to be around $1 million. And that, like the ACO, the quality is determining how much of the shared savings that we get. So it's the same kind of model. So all in all, our value-based programs are rewarding Health and Hospitals for investing in preventative outreach and care coordination, which should translate to better patient care by compensating for quality outcomes.
Great. I appreciate the translation. That's great. Better care for patients.
So as the New York City Health and Hospitals Managed Care team continues to advance this VBP portfolio, there are also some key strategic revenue initiatives that are owned by Managed Care that drive a lot of money for the system. And so I'm just going to quickly give you a snapshot of 3 of those programs. You can see here, this is our actual performance over the last 5 fiscal years. So we're bringing in a sizable amount of money. So how are we doing that, right? So next slide. So the first snapshot is trying to look at new revenue streams. So we determined around 2018 that there were dollars that Health and Hospitals was not collecting in the New York State Medicaid program that are tied to what we call high cost outliers. And so that means if you're serving a particularly complex patient cohort and they have really high spending during their inpatient stay, the Medicaid rate will price at a certain amount, but then you can also add in, based on your high charges, an additional amount of money that you're eligible for. And basically, Health and Hospitals, for a variety of reasons, were not getting paid that high cost outlier money for years and years and years. And so in 2018, we said, okay, we've got to try to fix this. We've got to work with the state. We're going to work with the health plans. And so I can report, as of last fiscal year, all 7 New York City-based Medicaid managed care plans are now contractually obligated to pay us our high-cost outliers. And that's generating more than $100 million of annual revenue that's coming in. So that's a renewable source of money that we had to fight for, but we got it, and that should be continuing. Another snapshot is trying to explore direct contracts with employer groups. How can we diversify our patient base and maybe try to be attractive to some commercially insured patients? And so since 2022, Health and Hospitals has held a contract with a large New York City-based union as a preferred provider of bariatric surgery procedures for employees that the union specifically refers to Health and Hospitals. So they can't just come in and say, I want a bariatric surgery. The employer is saying, we have authorized that we're going to pay for this, and we're going to then refer the patient to then have their clinical testing to see if they're a good fit. So we've had success over the last few years. We've done 76 surgeries. And because we've had a good partnership, that's leading to continued conversations about maybe we can expand beyond bariatric surgery. What other opportunities might we have? So that's one thing our team is working on. And then settling claims issues. So we have the normal revenue cycle process where we're billing claims and, God willing, collecting payment. But when we don't, we have a whole infrastructure that's following up with the insurance companies to try to work the claims. Our team often gets involved when there is a glitch, right? Where for our best efforts, we're not collecting all of the money that we think that we should. And so we will often pursue settlement agreements to try to close out timeframes and really try to fight for specific policy issues that we think have been misinterpreted or what. So in fiscal year 25, we concluded a tedious multi-year settlement with a payer on a lot of outpatient encounters that were from the height of COVID. And that was worth over $16 million. So that was a lot of work, but it was time well spent because we really were able to hold that payer accountable to paying out those claims. A slightly different example, we had an issue with a payer where they were misadjudicating some of our COVID test claims. And rather than settling one time, we decided to take the value of what we felt they owed us and embed it into a rate increase so that we would get that money in the current year, but then that would help us over time, right? Because normally the rates continue to trend upwards. So just another example of how we're trying to think creatively about how to be capturing as much money as we can.
Great. Any questions for Megan or comments?
John, so in the end, we believe it's $2 billion more a year of insurance revenue than
Yep.
when we got here.
When we started, yeah.
I mean, it's just right. I mean, so much of the difference was that nobody was doing anything.
Mm-hmm.
If the insurance paid, the insurance paid. If there needed to be a prior authorization, nobody did it. If the prior authorization got denied, nobody reapplied it.
The 2 billion includes the value-based care plus
Yep.
the revenue cycle.
Yep.
Right, but what it doesn't include is government, right, it's
Right.
not city, it's not the stuff that is lobbying. It's all the stuff that we do via insurance payments, right? And that's the difference in the end between a shrinking health and hospitals and a growing health and hospitals. And I mean, what I think is so amazing is it was all always there.
Right.
And none of it was really what I would call, I mean, it's incredible hard work, but none of it was genius. Right, I mean, all of these things are known how to do. It was just a question of our learning how to do it. And it is hard. I mean, it requires diligence, it requires surveillance, it requires people going in. It's not that it's easy to do, but the concepts are all straightforward, right? And other groups were doing it. Just somehow, for whatever reason, health and hospitals wasn't doing it.
Well, I think even beyond, it seems like we're moving towards things that are not so straightforward
Right.
and creative and being, because we've already done the low-hanging fruit, as you would say.
Yes, although we still periodically find a low-hanging fruit
Oh,
that
do
we
we?
missed, that we missed the previous time.
Good.
But yes, I mean, I think the finance team has just done, and the revenue team together have just done such amazing work, and it's what fuels the mission, right? It's what enables us to do all of the amazing services we do. That in the absence of this revenue, including the bond measure, right? We couldn't be doing the bond measure successfully if we were not living within our budget, right? So for our operating, so it's very impressive what this team has done.
When we talk about the 7 million in the ACO, for example, but this applies to any of the value-based care initiatives, does that include the cost of running that program?
It does.
So you already net that out?
We net
That's-
that out.
Thanks.
Well, let me clarify. When we get the distribution,
Yeah.
so the ACO is a very distinct model where all of that money is, majority of that money is being funded directly to the doctors, right? And we keep a very specific list of doctors that are participating in the program. So when we get that distribution, there's a contractual amount off the top that goes to administrative purposes. But I can tell you it's quite small in terms of
Compared to-
most of the money is going directly to the doctors. So there is the incentive to, continue to do more and more and more.
Thanks.
And I'll just say, I mean, the numbers are all good, but there's a very much a common recognition that we can do better, right? That is definitely there. It's a goal, plan to do that, but
I-
I don't think we're not gonna.
The direct contract with employer groups, that sounds very promising.
Yep. Yeah, we're good value, right? I think we are good value. Our costs are structures tend to be lower, and our value performance is kind of speaking for itself, and it's a great combination to have in healthcare, right?
Any other questions? Herc, Ted.
So, thank you for a couple minutes today. Just to set the stage, the last few years have been challenging for us to put together the program that we're about to talk about the outcomes for. But I wanted to start by saying thank you to each of you for your constant support in helping us to achieve these really incredible humanitarian outcomes for our city and for everybody coming to our city. And a special thank you to DHS for being our constant partner every step of the way. So thank you. So today, what I'm going to do is just share with you some of the high-level numbers that show the impact that we've been able to have together. So we provided in our through our humanitarian centers temporary shelter and services to 140,000 plus asylum seekers. That's 140,000 people stayed at our sites. That included 40,000 children. At peak, we had 16 large humanitarian centers, and at any given moment, we were housing 25,000 plus people. Approximately 3/4 of those were families with children. We delivered 40 million culturally relevant, all halal certified meals from day one. And we distributed over 10 million baby wipes, 2.6 million diapers, 700,000 formula bottles, and baby food jars. At our arrival center, which is something that we worked incredibly hard on and that we're incredibly proud of, we provided services to 155,000 individuals. They came from more than 160 different countries, speaking more than 60 different languages. At the arrival center, we overall had over 300,000 visits from May 2023 to June 2025. We coordinated arrivals of asylum seekers from 800 plus buses and 7 planes. We provide 100,000 vaccines at our humanitarian centers and our arrival center together, the majority of which were things like measles vaccines, both to protect our children, but also to have them enroll in school quickly. Next slide, please. From a case management point of view, this is something that we had drew from our experience at Health and Hospitals in order to set up the program to support people seeking asylum come into our city. We conducted 1 million case management meetings with asylum seekers. We reached 99% of all of these humanitarian center guests at our sites with ongoing support. We helped support asylum seekers completing 111,000 work authorization, TPS, and asylum applications. And this last one is one I'm particularly proud of. If you were to go to any of our sites throughout and say, what's the number one thing you want? How can we help you today? People would say we want to work. So we helped more than 90% of all eligible adults apply for or receive work authorization through our case management program that we built brick by brick. We also formed a community advisory board to help to make sure that we're getting this right and to help to engage the organizations that have been doing this work that we learned from DHS for decades. We had 30 organizations that came, including DHS, to all of our meetings. And that helped to inform our efforts and really is the grassroots approach that we took for COVID and took for how we addressed MPOX as well. Go ahead and go to the next slide. I'm going to pass it for the financials.
Financial update, we currently oversee one PERC site serving about 3,000 guests a day. We committed $868 million of PERC expenses in FY25 on behalf of the city. The city allocated $960 million in 25 and $76.4 in 26 to the HERC program, to H&H's HERC program, in their FY26 adopt plan. To date, OMB has provided H&H with sufficient revenue to cover all expenses through our MOU with the mayor's office.
What is the plan for the one that's left?
So we have, the city holds the lease for that site until I think around April of next year. So we're working with DHS to continue to operate the site as long as the city needs it to be operated.
And then presumably you might choose a different site. You might not maintain this site.
Well, this site is 3,000 a day, that capacity.
I see.
Yeah, we're making plans to, with DHS to have the families that are currently there transition into other existing DHS sites, things like that.
Got it. Good.
So through April. So this might be one of our last updates. But
that is our intention.
yeah, but it's just amazing. I think the catalog that you went through, Ted, is wonderful in terms of the program and management of it and the collaboration with the city.
I might add that, you always say thank you to us, but I know Chris and Ted.
Yes.
I mean, I feel like I know them, like,
Right.
if I think I dreamt about them yesterday, I might have, because people are calls with them every day. Diligent, but we all climbed the hill together, we summited together, and, now we're trying to close out together. So thank you guys, this was great work. Appreciate it.
You are more than welcome. It was an honor.
I just want to add, I mean, visiting the sites, meeting the people, you can tell you put your heart in it. It was quality work. Just bravo. Thank you for the hard work for you and your team. Thanks.
Thank you very much. If I could just take the opportunity to also say just publicly thank you to Chris and our whole team that really moved heaven and earth to accomplish these incredible things for everybody coming to us.
Great.
Thank you.
Final presentation.
Okay. Well, on this topic.
That's all right.
All right, thank you. If no other comments, we have one more topic on the bond measure issuance that Mitch mentioned.
Yeah, this is going to be a very quick update on our bond deal. If you may recall, back in July, the board has authorized the corporations to issue bonds in amount not to exceed $250 million. So in August, we did just that. We went to the market, and you can see that picture there on the right, which is showing the cover of our offering document. In the final amount that we issued was $242,850,000 in tax-exempt fixed rate health system bonds. We used the money to fund our project fund for capital projects, funded the capital reserve requirement, cost of issuance. And then so far we have drawn about $30 million from the project fund for various capital projects. In terms of the deal itself, it was very well received. We attracted new buyers. We got about 5 times oversubscription on the sales order. And we were also able to accelerate our deal from 2 day into 1 day. So overall, the deal met expectation in terms of pricing. So that was it.
We've talked before, I'd just like to know the plan going forward, remind me. The, you only draw out the money as we have the capital projects going, so that we don't pay interest for money we can't use. So that I think is great. But I feel like we agreed that there's another potential 250, right? Because I know while the 250 you have is not in contract, it's all spent in people's minds. That is, each hospital knows what it's going to spend its share on, and each hospital has additional needs. So what if we wanted to gain more bond beyond the 250? Is there something we do? I feel like I heard that it was pre-sold, but I'm confused perhaps.
Okay, so there are a couple of components in there. Capital project we're funded in this particular issues that is basically encumbered for already. Some of them are already spent and some of them are paid for. So we use this bond proceed to reimburse us of what's already been paid out. So for the next financing, we need to find another chunk of project finance that can be financed in the next bond issues. So for the purpose of this bond issue, the portfolio, we have identified the capital project that either already spent or will be spent by January of 2027.
27.
Right.
So the expectation would be to do another 250 million or
Right.
some amount.
Right, and some amount by, let's call it by next fall, where we teed it up for next bond financing.
Yeah, I think we're trying to get into like a sequence perhaps of going to the
Right.
market, because we have such great
So many needs,
Yeah.
right?
Yeah.
And the interest rate that we pay is fixed or variable?
This is a fixed rate.
The people will always get 4.3 no matter what the market does.
Right, you're reading off the all-in interest cost, it's roughly 4%. But in terms of the interest payment that's being paid out on semi-annual for these bonds, are roughly 5% coupon.
But we've locked in on the rate.
We locked it in. It's fixed rate.
But it's relevant because if interest rates do go down next year, well, two things. First, then you could do another bond measure perhaps at better.
Yep.
Can you refinance or pay out this bond?
This bond is not callable until 9 years later. It's the optional call that we put on this particular bond.
Got it. Okay.
But we evaluate that, whether we want to go fixed or variable, like that's all part of our evaluation process, right, Tom? Yeah.
Okay.
And we've done very well in the past on interest rates, right? We've hit the market at the right time on past bond issuances, but yeah, we evaluate all of this when we make a decision.
Yes.
If we're gonna keep going to the market, right, and we're gonna do another 250, and then hopefully we can keep that
Yeah.
going annually.
Frida, what is the lowest that a bond like this in recent history could go for?
Well, our
an
2020
interest rate.
financing was 2.8
Yeah, it was
or
about,
something.
let's call it 1.5. In that last deal in 2020, it was in an interest cycle that was really low at that moment, before the Federal Reserve went on the rate action and increased several rate hike after that.
But we do have variable rates still outstanding, so to your point on some of our, so interest rates might be coming down, we do benefit from that, because this is just one
Sure.
issuance in the whole portfolio, and so we have, these are slightly higher, our 2020 fixed rate bonds are much lower, and then we have variable rate, which went up for a while, because short-term rates were high for the last year or two, but they had been very, very low, and now they're expected to come back down. So we do have a mix of things that help us to smooth out. And then to John's point on trying to get into a cycle of borrowing where we're not, like rather than do one giant deal, have a lot of proceeds at one time at this 4.2%, splitting it into these chunks as the team has done, meaning do one deal this year, another deal later next year. You kind of dollar cost average into your
Sure.
rates.
That makes sense.
And just add to your point about refinancing, so in 2020 deal, that deal has a new money component, which is similar to this deal, but it also took advantage of the low rate environment and refinanced some of the older deal to capture savings there as well.
Understood. Thank you.
But we have plenty of needs.
Plenty of needs.
And all these great revenue improvements are helping us to continue to take care of those needs. Any other questions or comments on anything, on the bonds or anything the finance team has presented? Great. Well, thank you very much again. I'm glad we had some time to go through all the great work. And we'll look forward to other updates from you, Ted, but we certainly will look forward to hearing more about revenue cycle and managed care and all the strategic initiatives. So is there any old business or new business from committee members to bring before the committee? There being no further issues, the meeting is adjourned. Thank you.
This meeting is no longer being recorded.
This meeting is being transcribed and summarized.